Acute coronary syndrome may result in cardiac arrest if EMS and hospital providers do not respond quickly to signs and symptoms of chest pain or cardiac insufficiency. Acute coronary syndrome occurs due to a blockage in the heart. This blockage prevents blood flow to the heart, which results in muscle ischemia and possibly death. The best treatment for ACS is timely cardiac intervention focused on reestablishing blood flow. Many patients have varying degrees of atherosclerosis. In early plaque formation, the blood can easily pass through the arteries, but as plaque formation continues, more pressure is placed on the area of plaque as blood attempts to flow through the vessel. This plaque may rupture, which causes the clotting cascade to create a large clot. This clot prevents the passage of blood, which results in oxygen deprivation in the tissues of the heart. Since the heart muscle cannot get oxygen without blood flow, areas affected by the blockage begin to die. This cell death often causes the classic signs of chest pain in patients. These symptoms include chest pain, which may be described as crushing, pressure, fullness, or tightness. The pain usually lasts for more than several minutes and may radiate to the shoulder, down the arm, or up the neck. Chest pain may also be accompanied by shortness of breath, lightheadedness, sweating, nausea, or vomiting. Any of these signs and symptoms in a patient should indicate the need for a 12-lead ECG. It is important to note that women are more likely to experience nonspecific symptoms of ACS, including back pain, abdominal pain, or jaw pain. Do not rule these symptoms out until a diagnostic 12-lead ECG has been performed. Stable chest pain may occur during activity or anxiety, but is relieved by rest or medications like nitroglycerin. Unstable angina is the sudden onset of chest pain that starts while the patient is at rest or is not relieved by rest. It lasts longer and may cause other symptoms like shortness of breath, diaphoresis, or a sense of impending doom. Again, any chest pain should immediately warrant an ECG. The purpose of this ECG is to use the electrical signals of the heart to determine if there is a blockage and which portion of the heart is blocked. An ECG should be done as soon as possible with a goal of less than 10 minutes. ST segment elevation is indicative of cardiac damage, while patients with ST depression may have worsening ischemia that may become damaged. In patients with a complete blockage, the ST segment is elevated more than 1 millimeter and more than 2 consecutive leads. ECG findings should be transmitted from the field if possible. The hospital team should transmit new or incoming ECGs to a cardiologist or interventionalist as soon as possible to prepare for intervention. Myocardial infarction is apparent with ST elevation. The 12-lead EKG can be grouped into continuous lead complexes, which help determine the location of MI. Lateral MIs include leads 1, AVL, V5, and V6. The inferior leads include 2, 3, and AVF. In septal MIs, elevation can be seen in leads V1 and V2. Anterior MIs are seen in leads V3 and V4. A 15-lead ECG may be necessary to see the right ventricular and posterior MI. Patients with unresolved pain or cardiac symptoms with no ST elevation noted on a 12-lead ECG may benefit from 15-lead analysis. To further analyze the heart, serum cardiac markers may be used. Myocardial infarction results in the release of several enzymes and proteins which may be used to determine the timeline of the heart attack. Most commonly, troponins are used to measure acute chest pain because they increase 3 to 5 hours after myocardial infarction and remain elevated up to 10 days. The ACS algorithm starts with recognition. You should assume any sign or symptom of a heart attack is a life-threatening STEMI until proven otherwise. Your first goal is recognition, followed closely by obtaining a diagnostic quality ECG. This includes correct sticker placement and skin preparation. Once you have determined the result of the EKG, you can monitor and support the systems in your primary survey. Many chest pain patients benefit from oxygen supplementation to oxygen percentages of at least 94% or greater. Too much oxygen may be detrimental, so titrate oxygen support once the patient reaches 94% or higher. Patients who are suffering from ACS are more likely to have deadly arrhythmias, so you should immediately apply defibrillation pads and monitoring stickers. By performing this action early, you can more quickly intervene in cardiac arrest. It is important for patients experiencing ACS symptoms to receive 325 milligrams of aspirin by mouth. Patients should chew this aspirin even if they have the ability to swallow. Aspirin absorbs better when chewed. There are not many contraindications for aspirin therapy. It should be avoided in patients with a true aspirin allergy or if the patient has already taken aspirin before arrival or symptoms started. If the patient has a history of GI bleeding or is unable to tolerate aspirin PO, use a rectal suppository. Another common medication for chest pain patients is nitroglycerin. This fast-acting vasodilator causes arteries and veins to expand, resulting in a decrease in preload. You should administer one spray or sublingual pill every 3 to 5 minutes. Chest pain that is alleviated by nitro is a sign that ACS symptoms are present but does not indicate STEMI or non-STEMI. You can administer a total of 3 doses but should carefully monitor blood pressure. Do not administer nitro in patients with a blood pressure less than 90 systolic. It should also be used cautiously in patients who are having an inferior wall or right ventricle infarction, as these patients are very dependent on preload. Again, do not administer nitrates in the presence of low blood pressures less than 90 systolic, or if the patient has marked bradycardia or tachycardia, as the heart may not be able to accommodate vasodilation. Nitrates are also contraindicated in patients who have recently taken phosphodiesterase inhibitors. These include sildenafil or vardenafil, commonly known as Viagra or Levitra for erectile dysfunction or pulmonary hypertension. These drugs may cause severe hypotension when taken within 24 to 48 hours of nitrate administration. For patients whose pain is not well controlled after nitro, consider using opiates like morphine. This should be used with caution in STEMI patients, but may be beneficial in patients who have ST elevation. Morphine reduces cardiac demand and decreases vascular resistance. Keep in mind that morphine is also a vasodilator, which when used with nitro may result in hypotension. Fluids should be administered to patients who develop hypotension. An easy way to remember critical treatments for ACS symptoms is the acronym MONA, which stands for morphine, oxygen, nitrates, and aspirin. Patients who are having a STEMI and some unstable non-STEMI patients benefit the most from rapid identification and reperfusion therapy. This therapy may include transport to a facility capable of performing cardiac diagnostics and treatments, including percutaneous cardiac intervention or PCI. Treatment with PCI should occur within 90 minutes of initial medical contact for hospitals capable of performing intervention and up to 120 minutes if the patient requires transport to a center capable of PCI. PCI is the treatment of choice for many patients and uses a balloon to reopen closed arteries, followed by a stent to keep the artery open. For some patients, this may be a temporary measure until open heart surgery, but for many patients, this life-saving intervention will result in an open vessel and a decrease in cardiac damage. Patients who cannot undergo immediate PCI and who have not had symptoms for greater than 24 hours may benefit from fibrinolytic therapy, which can open the blocked vessel in about 50% of ACS patients. These drugs include alteplase, or TPA, retiplase, and tenecteplase. These drugs should be given with caution in patients who have bleeding risks because bleeding is a significant side effect of the medications.